The meeting is live now. Please start the meeting.
Good evening, everyone. Welcome you all to the 11th session of KSOS PG Classroom. We've been alternating between a case-based discussion and an investigation in ophthalmology. Last week we had OCT, we had discussion on OCT. And today we'll be having another interesting case-based discussion. And this will be done by Calicut Medical College. And we have expert faculty here to discuss the case. And Gopal sir will be introducing the faculty.
Okay. Am I audible?
Yes, sir.
Yeah. So thank you, Rehna. We are on to the 11th edition of our ophthalmology classroom. So this time we have a glaucoma case presentation presented by Calicut Medical College. We are really happy to have with us Dr. Kirti Singh, who is the director of the Guru Nanak Eye Center, Mamsi, New Delhi. She's an excellent academician, teacher, researcher, and has done a lot of work in glaucoma, as well as she is a passionate teacher, and her teacher's training methodology is what is her passion also. So we look forward to hearing from you, ma'am, and discussing and dissecting this case, really well. And we have our own host examiner, Dr. Sandhya Somasundaram, who is Associate Professor of Ophthalmology at Calicut Medical College. And Dr. Delma will be presenting, and without wasting any more time, let us move over to Delma. Can we share our presentation? And next time we will be doing a retina spotters. So we will, over the next, over the 1 hour, we will discuss about 25 or 30 retina spotters. Over to you, Delma.
Elma, you can start sharing your presentation. I think she has gone out. Elma, yes.
Please make sure that you don't tell the name of the patient or anything like that, because we are in YouTube, and we have to have confidentiality for patients. All right.
Am I audible?
Yes.
Yes.
Is my screen visible? My presentation?
Yes, yes.
Shall I start, sir?
Yes, please start.
Presenting the case of a 65-year-old male who is a farmer who's coming from Nilambur, who presented with complaints of pain and defective vision in right eye for 1 week. History of presenting illness. 65-year-old male presented with no history of any comorbidities, presented with complaints of pain and defective vision in right eye for 1 week. Pain was severe aching type which radiated to the right forehead and back of his head, and was associated with redness, watering from the right eyes, and nausea. History of colored halos were present. He consulted a local hospital the next day and was given tablets and eye drops, and he had symptomatic relief. 2 days after stopping the medications, he developed severe eye pain, which was associated with nausea, and he was referred to Medical College, Calicut. He also had defective vision right eye, which he noticed 4 months back, and he had worsening of this defective vision right eye after he developed pain. The defective vision also improved with medications prescribed from the local hospital. No history of any similar illness in the past. No history of flashes, floaters, micropsia, macropsia, or metamorphosia. No history of transient loss of vision in the past. No history of trauma to right eye. Past history. No history of diabetes, systemic hypertension, dyslipidemia, coronary artery disease or cerebrovascular accidents in the past. No history of any ocular surgeries in the past. Personal history, he is a chronic smoker and an occasional alcoholic. Treatment history, he is not on any regular systemic medications. On examination, General examination, he was conscious, oriented, and cooperative, moderately built and nourished. There was no pallor, icterus, cyanosis, clubbing, lymphadenopathy, or edema. Vitals, blood pressure was 120/70 millimeters of mercury in right forearm supine position. Pulse rate was 80 beats per minute, regular rhythm and volume. Rate was 26 per minute, and the patient was febrile. Systemic examination was within normal limits.
Just go back one slide back, please. Go back. Yeah, the vitals. Just talk about the pulse.
Pulse rate.
You are talking about a patient now. At this point, I would just like to see what else have you seen in the pulse.
Pulse was regular in rhythm and volume.
Which side is the pain? Which side is the glaucoma?
Right eye.
So you should have seen both sides, both arms. Okay, carotid you said both bilateral, but for the arms you haven't said. We'll come to it afterwards. Carry on.
Madam, do you wish to discuss history here?
No, it's okay. Let's let her finish. Otherwise, it will become very erratic. I've just raised the point that she should have seen in both arms. Okay. Carry on.
Systemic examination. CVS first and second heart sounds were heard. There were no murmurs. CNS examination. Higher mental functions were within normal limits. There were no any focal neurological deficit. Respiratory system, normal viable breath sounds heard bilaterally. There were no added sounds. GIT, per abdomen was soft and non-tender. There was no organomegaly. Ocular examination was orthophoric. There was no facial asymmetry. Extraocular movements, ductions, versions, and versions were full in both eyes. Slit lamp and torchlight examination combined. First, right eye. Lid and adnexa was normal. Conjunctiva, ciliary congestion was present. Cornea was hazy. Epithelial and stromal edema was present. Microbullae was present. Anterior chamber, Van Herrick's grade 2. Cells of grade 1+ was present. There was no flare. There was no hyphema. Iris, normal color. Fine tuft of arborizing vessels with low caliber was seen along the pupillary margin 360°, suggestive of neovascularization of the iris. 360° ectropion UVA was present. There was no peripheral anterocyanic or atrophic patches in the iris or peripheral iridotomy. Pupil central, round, size 5 mm was dilated pharmacologically. This is a slit lamp picture showing ectropion UVA 360°. There was also neovascularization along the pupillary border, which is not well appreciated.
Go back one slide. Go back one slide again. Back. You are said here ciliary congestion, right?
Yeah,
and now go forward. Where is the ciliary congestion in this picture?
Madam, this picture was taken after his IOP was reduced, and he had symptoms 2 days after the admission. So
you don't have the previous picture?
No, ma'am, sir.
Then you should have said this when you are presenting the case, that this patient doesn't have the ciliary congestion right now. Circumcorneal congestion has reduced because of treatment. Even the cornea is much clearer.
Yes, ma'am.
Right?
Yes.
Okay. Pupil dilated. You have said pupil dilated iatrogenic. That was at the time of presentation.
Yeah, yes, ma'am. At the time of presentation, also his pupil was dilated pharmacology.
Why is it important to know what the pupil status is? Then you should have checked without dilatation. Why? Especially in a case like this, what is the implication of the pupil?
It could be shape of the pupil. It could be vertically oval.
No, before dilating.
Just keep this in mind. I'm going to ask you this pupil and this pulse. Remember, we talked about the pulse both sides, circumcorneal congestion, CCC, and we're talking about the pupil. Carry on. Carry on, beta.
Lens, central anterior subcapsular opacity was present. Nuclear sclerosis grade 1 was present. Intraocular pressure by non-contact tonometry at the time of admission was 55 millimeters of mercury. Gonioscopy done after the corneal edema has cleared, revealed Sharper's grading 1 in all 4 quadrants, and there was neovascularization at the superior quadrant. Fundus examination. Right eye, the media was hazy due to lens opacity. The disc was vertically oval, normal in size. The margins were well defined. Cup disc ratio was 0.3. The neuroretinal rim was pale, and there were a few fine vessels in arborizing pattern of along the nasal margin of size less than 1 disc diameter, suggestive of neovascularization of the disc. The vessels were seen arousing from the center of the disc, branching dichotomously, maintaining an AV ratio of arteriovenous ratio of 2:3. Sclerosed vessels were seen in the infratemporal quadrant, and multiple superficial hemorrhages were seen along this infratemporal arcade extending up to the mid-periphery. Foveolar reflex was dull. There was no signs of, no evidence of NVE or no evidence of AV crossing changes. This is a picture of fundus, right eye fundus of the patient. Moving on to the ocular examination of the left eye. Anterior segments were within normal limits. Pupil, direct reflex was brisk and concentric reflex was sluggish. Non-contact tonometry at the time of the admission was 15.7 millimeters of mercury, and gonioscopy, Sharper's grading 2 in all 4 quadrants. Fundus examination of left eye. Media was clear. Disc was vertically oval. Disc margins were well defined. The cup disc ratio was 0.2, and the neuroretinal rim was pink. And the vessels were seen arising from the disc, branching dichotomously, maintaining an arteriovenous ratio of about 2:3. The foveolar reflex was dull, and multiple superficial hemorrhages were seen along the supratemporal arcade, along one of its branches, extending up to the mid-periphery, suggestive of a venous occlusion. So this is a fundus picture of the left eye. Functional examination, vision of right eye, 3-meter counting fingers, not improving with pinhole. Left eye, best corrected British acuity was 6/9. Neo vision, N36 in right eye and N6 in left eye. Summary. 65-year-old male who was a chronic smoker, presented with complaints of pain and worsening of defective vision right eye since 1 week. On examination, right eye showed ciliary congestion. The cornea was hazy and iris showed 360 degree of neovascularization, ectropia, and UVA. On gonioscopy, occludable angle with neovascularization at superior quadrant was seen. Fundus examination showed a pale disc with neovascularization of disc at the margin, sclerosed vessels infratemporally with superficial hemorrhages along the arcade extending up to the mid-periphery, suggestive of venous occlusion. Intraocular pressure measured with non-contact tonometry at the time of admission showed 52 millimeters of mercury in right eye. Left eye fundus showed features suggestive of a branched vein occlusion along the supratemporal arcade.
Go back, just go back, go back. Left eye had supratemporal BRU, but the picture, just show the left eye picture. Where is the supratemporal BRBO in this eye?
Madam, this is superficial.
Sorry?
Ma'am, the hemorrhage is seen along the supratemporal arc.
It looks like the infratemporal. Go back. It is in the inferior quadrant. It's not in the superior quadrant as far as I can see, unless it's an everted image. It is not. Inside the cyclotorsion, the fovea is, this is fine. It is superior. Yeah, this is superior is normal. Go inferior, and the hemorrhage is here, inferior. Yeah. So it's very much further down.
Ma'am, some of the
Looks
hemorrhages
more
were-
like the inferior. If you find the inferior vessel is not very well delineated, and the inferior vein is definitely more tortuous as it comes out at the disc. Just point the inferior vein. Yeah, this one. Can you see this?
yes, ma'am.
Compared to the superior branch, this is more tortuous. And this is the artery. The other one is the artery. This is the vein is here. This is the vein. That one is the artery. Is it a BRAO? This is the vein. Artery
This is a vein, ma'am.
And where is the artery? Where is the artery? This is the
this is the
artery. Yeah,
artery.
trace the artery. No, not this.
This is the artery and this is a vein.
Superior.
Superior,
No.
this is the
The artery, inferior central inferior branch retinal artery. The next one. ये तो vein है ना? This is the BR
this is vein.
branch retinal vein. Now look at the inferior division of the artery. Central retinal artery inferior division. This one. Trace it. Yeah. Keep tracing. See there. You have the hemorrhages there. You don't have the hemorrhages at in the pathway of the vein, although the vein is tortuous. Was an angiography done?
No, ma'am. Angiography was not done.
Sorry?
Angiography was not done, ma'am.
Okay. So we'll come to all those points. Can you understand what I'm saying?
Yes, ma'am.
It is in the inferior quadrant. How would you know that this fundus picture is not slipped? Where should the fovea be normally? Inferior to the center of the disc or superior?
Inferior.
Is it the right eye or is it the left eye?
This is a left eye fundus picture. ma'am.
Why? Because it's written it's a left eye. How will you make out if it's a right eye or the left eye? Anybody? Dr. Gopal said ask questions to somebody else.
Yes, ma'am.
Anybody wants to tell me?
Ma'am, fovea is in temporal to the disc.
Say it again.
Ma'am, the fovea is seen in the
Fovea
temporal
is
to the
seen.
disc.
Fovea is seen where? Yes.
Temporal to the disc and inferior. And the
Anybody
description
else wants? What is your name, Bitra?
Elma, madam.
Hmm?
Elma.
Ma'am,
What is your name?
my name is Elma.
Elma. Anybody else? Other one wants to talk?
Yes, Gidu, you can answer, Gidu. Gidu, are you there? Yes, please answer,
Optic
madam.
disc is present nasally. So this is left eye.
Clear, Gidu. Okay, Jovita.
Hello,
Yes, Gidu. Now, okay.
madam. Optic disc is present nasally. So this is left eye.
Is always there. It's the optic disc. Is the fovea present in the center of the optic disc? Is it in the 1/3, 2/3 junction? Superior, inferior? How is it? Fovea is always in the inferior 1/3, 2/3. Okay. If you divide the disc into 3 quadrants, it is at the junction of the upper 2/3 with 1/3. That is how you check for excyclotorsion and encyclotorsion in strabismus cases. Yes? Hello.
Hello, ma'am.
Let me just get a Dr. Sandra. Sandra, who's the other faculty with me, please?
It's me, madam. I'm Sandhya.
Sandhya, just take over. I'll just see if I can find a textbook to show them. They seem to be.
Okay. So, Elma, here madam said no. Hemorrhages, you can see in the close to the inferior branch. Some hemorrhages you can see superiorly also, right?
Yes, ma'am.
Okay. So, what was the finding in the other eye?
In the other eye, ma'am, fundus finding.
Yeah, fundus finding.
Other eye media was little hazy due to the lenticular opacity, but we could see a sclerosed vessel infratemporally.
Okay.
And
you could
hemorrhages were seen along the infratemporal arcade, which was extending up to the mid-periphery also. Okay. And there was neovascularization of the disc along the nasal margin.
How could you tell that it is neovascularization of disc? What are the other abnormal vessels which you can see over the disc?
The vessels were of very fine caliber,
okay.
In arborizing pattern.
Yes.
Very fine tuft of vessels of arborizing pattern with low caliber was seen, which was suggestive of neovascularization.
Okay. Any other abnormal vessels which you can see over the disc apart from neovascularization? Any, especially in vascular occlusions?
Pallor of the disc.
Abnormal vessels. Collaterals. Have you heard of collaterals? Yeah. What are collaterals?
Collaterals.
Shunt vessels, basically.
Shunt vessels from the optociliary vessels from the inferior corona.
Optociliary shunt vessels are there, yes. Okay. Then, any other abnormal vessels like in diabetic papillopathy or even in non-arthritic ischemic optic neuropathy? What type of you can see, fine vessels over the.
Okay, I just couldn't find a book. Am I audible?
Yes, madam.
Look at this. In cyclotorsion and excyclotorsion, always the fovea is at the junction of 1/3, 2/3, and if the fovea is up, that means it's in cyclotorsion or cyclotorsion. So even if the fundus picture is flipped, okay, even then you can know if it is right side or left side because the fovea will be in the inferior part of the disc. Okay. So this patient is, this is the, yeah, so this is the left eye. Okay, the fovea is inferior, right? So that is what I'm saying. This is an infratemporal, from my point of view, it looks like infratemporal BRVO in the left eye. BRAO, sorry. Is Dr. Gopal there? Gopal, are you there?
Yes, ma'am. Yes, ma'am. Tell me, ma'am.
Do you agree with me? This fundus picture seems to show that it's an infratemporal BRAO rather than an infratemporal, supratemporal BRAO.
Let me just open my laptop, ma'am. 1 second. Let me just open my laptop. Okay, cool.
Okay, what was the student's name again? I'm sorry, I'm forgetting name. Sela. What was the name, bache?
Elma.
Elma. Okay. Elma, let's come to what. So what is your diagnosis, differential diagnosis based on this short history and this examination finding? Summary, you said 65-year-old male smoker with history of vision diminution, right eye, and BRPO, and you said both sides BRPO. What do you think is the diagnosis?
Diagnosis, neovascular glaucoma.
NVG in this eye?
Closed angle stage in right eye.
Right eye. So NVG, closed angle stage in the right eye, subsequent to? Subsequent to vascular occlusion.
Vascular occlusion. Yeah.
And the vascular occlusion which you are telling us, go back to the right eye. Yeah. Right eye you are showing, this is supratemporal. Yeah, this is
Ma'am, this is what I'm asking, ma'am, whether this is arterial occlusion.
no, not this side, the other eye, left eye. Show the left eye to Dr. Gopal. Yeah, this eye. This eye is inferior.
Yeah, ma'am, I think there is inferior vessel is a little more dilated and tortuous.
Yeah, even the artery, the hemorrhages are next to the artery.
Yeah, but the hemorrhages are not a feature of arterial occlusion, no, and there is no.
They are not. They are not.
They are not. There is no.
Exactly. That is why I asked, did you do an angiography? Did you find out the confirmation? But
yeah.
So this patient has bilateral vascular occlusions.
Other eye, superior vascular occlusion. Other eye, can I see the other eye, please?
Other eye superior. This eye is inferior.
Sir, right eye, we could see inferiorly the vessels were sclerosed and hemorrhages were seen along there. But it is not visible in this picture.
Sclerosed vessel cannot be visible in this picture. Again, Elma, what you should have done is always make a diagram. Okay, draw a diagram. You have the picture fine. In the exam, you won't have that. You should always learn to make a diagram. Can you see this diagram of mine?
Yes, ma'am.
Is it visible?
Yes.
So always make a diagram where, and you will show how much is the NVD. Is it a significant NVD?
Yes, ma'am.
What is the DRS study talks about? How much is significant? Is NVD always significant or NVE is significant?
NVD involving
NVD is always significant. Okay. So that is the first study ever, international or national, on any disease was the DRS, diabetic retinopathy study, DRS. You must read out DRS and ETDRS. Okay. So this patient has sclerosed vessel. You said infratemporal. नहीं, infratemporal तो यहाँ भी नहीं है. This is supratemporal.
Elma or Delma?
Elma. Is it
Elma,
supratemporal? This is not infratemporal. Here also it's superior.
Yeah, Elma, I want to tell you that these are photographs which you've taken from a photograph. Right? So are these so you should have taken a digital picture and shown, which should have made it much more clear.
Drawn a diagram. Always draw a diagram. In the exam also, you will, if you draw a diagram, it fetches you much more marks. Okay. So you should draw a diagram. So this appears to be superior in this eye and inferior in the other eye. Both eyes may
be. Is the supratemporal area completely pale as compared to the infratemporal area?
In fact, it is more supranasal here, but it should be supratemporal normally. Why is supratemporal more common than supranasal? Why is vascular occlusion more common in the supratemporal area vis-a-vis supranasal area, or infratemporal vis-a-vis infranasal? Any idea, Elma? Can I have the names of the other students, because I don't know who they are?
Yes, madam. I can ask, madam. Najla.
Sorry?
Najla, madam. Najla.
Najla. Yes, Najla. Why is you always hear temporal? Why temporal quadrant is more prone to vascular occlusions?
Madam, probably because AV crossing is more.
Yes, good. So AV crossing changes are more in the temporal quadrant. It has a longer course to run. So it is more common in the temporal quadrants. So here it appears to me is in the supranasal, but I'm not sure on this. It could be either. But you do feel it's there. There's an NVD. Obviously the media is hazy. So repeating for the last time that you should have had a diagram. Okay, now let's come to the history points which I had that time just highlighted. What are the causes, Elma, of neovascular glaucoma in a 65-year-old patient?
Any events which can cause retinal ischemia, diabetic retinopathy,
DR retinopathy. Does he have any diabetes?
No, ma'am. He's not a
History
diabetic.
wise, nahi. What are the other things you would like to test? Patient may say he has nothing. Would you believe the patient? What test would you do?
I would like to do a fasting glucose level, also an HbA1c level.
Fasting PP both. Postprandial and fasting both, and HbA1c to rule out diabetes. Okay, so first thing you rule out is diabetes because that's the commonest cause of neovascular glaucoma. Second common cause?
So central retinal vein occlusion.
Central retinal vein occlusion. You want to specify which type of CRVO causes more
ischemic.
Of ischemic. How will you? That is exactly what I wanted to ask you. How will you differentiate clinically a ischemic vascular occlusion from a non-ischemic?
Ischemic occlusions will be having visual functions will be more affected in an ischemic CRVO.
Okay, so poorer vision. Second,
poorer vision. The presence of RAPD.
Exactly. So, आपने बोला this. You said you have examined the patient with iatrogenically dilated pupil. Okay. In the exam also for a retinal case, you will get a dilated pupil. But you should say, I would like to examine the patient without dilatation. And this patient was in the ward with you. You should have examined undilated so that you know how much is the RAPD. You have said from the left eye, you have said that there is a consensual is poor, but you should have done a undilated examination, correct? Because RAPD will tell you whether it's ischemic. What is the other feature? One is vision, one is pupil. What else?
Presence of this neovascularization will be more in an ischemic.
No, that's okay. What are the other? Now this has already, how much time you think has elapsed before the vascular occlusion happened? What is the classical term given to the vascular occlusion, post-vascular occlusion glaucoma?
90-day glaucoma.
90-day or 100-day glaucoma. So this patient had the occlusion episode at least 3 months before, right? Maybe longer, because he has developed NVD. NVD doesn't happen that rapidly. Plus, what are the other features? Now, this patient has established NVG. We're talking about the rapid afferent pupillary defect and the vision when the patient comes to you with a vascular occlusion prior to developing a NVG. Have you understood? Because the pupil will prognosticate that whether this patient will go into NVG or not, or rubeosis or not. So this patient has crossed that journey, that path, that time has elapsed. Now already he is into a frank NVG with NVD and NVI. What are the other signs in this patient which tell you that it's a very long-standing occlusion? One is NVD, one is NVI. Third thing?
Presence of an ectropy on UVA.
So 360 degrees ectropy on UVA. It would have taken many months for that to happen. Go back to the picture of the anterior segment. Okay. So yeah, ectropy on UVA. You said that the vessels were there in the pupillary area. You can see the radius. Supposing I tell you that no, these vessels, Dr. Elma, are normal vessels which are just being visible because of the iris atrophy. How will you say, no, ma'am, you're wrong? Tell me the features of abnormal vessels vis-a-vis normal iris vessels.
Abnormal vessels will be found in the pupillary area, will be having a fine caliber and will be having a arborizing pattern, whereas the normal vessels will be more thicker and also having a radial course.
So the normal vessel will be radial. Number one, normal vessels will very, very rarely be visible, especially in us Indians who have a thick iris, thinner iris, Caucasians, light colored, you may see it. But otherwise in thick iris, it's very rarely visible. It will be visible once there is stromal atrophy. In that situation also, it will be radial, it will be deeper. So, and the abnormal vessels are superficial, arborizing, they will not follow a pattern. And it is also said when you have more of peripupillary, although it's not a hard fast rule, it is more commonly seen in diabetics. But although this patient, you have said that he's not, but I would still like to get the diabetic profile done. All right, so we've covered that. Go back to the next slide. Next slide. Next. Yeah. Now tell me, this gonioscopy is absolutely not as per protocol. Why?
Ma'am,
This goniogram is not as per protocol. Which classification are you following? Spades, Schaeffer's, Shees, RPCs, which classification?
Sharpest grading.
Huh?
Sharpest grading.
Sharp?
Schaeffer's.
So unless you write it, it is Schaeffer's grading, nobody will know. So the best way to draw a goniogram, again, your drawing will give you marks. Okay, the best way to draw would be, let's say 1. 1 means in Schaeffer's, that means the anterior TM is visible.
No, ma'am. Schwal baseline is seen up to Schwal baseline, and also
up to Schwal baseline. Now you also have to tell us the gonioscopy was indentation, manipulative. Which one would you want to do? Now you are saying this is ACG. Now this is a NVG ACG stage, right?
Yes, ma'am.
So ACG stage, what gonioscopy would you want to do?
Indentation.
Indentation. Which lens?
Indentation using a Posner 4 mirror.
Which one did you use, Dr. Alma?
I used a Goldman 2 mirror gonioscopy.
So Goldman 2 mirror, can you do an indentation with Goldman 2 mirror?
No, ma'am. Cannot do a indentation.
What is the next best thing you can do with Goldman 2 mirror?
Manipulation.
Manipulative. So there are 3 types of gonioscopy: static, manipulative, indentation. Indentation by norm, by definition, is by 4 mirror, whether it's Posner or it is by the Zeiss 4 mirror or it is by the Sussman 4 mirror. Whereas Goldman 1 mirror, 2 mirror or 3 mirror will cause static. By their movements, you can do manipulative. So what diagram you should have drawn was something like this. Schwal base, let's say you've done a Goldman 2 mirror. So Schwal base line with manipulation, Schwal base line with manipulation going to ATM, or Schwal base line with manipulation still Schwal base line. Okay. So this means manipulating. This arrow means manipulation.
Madam,
you have written NVA at superior quadrant.
Madam,
Which superior quadrant? 90 degrees, 12 o'clock to 1 o'clock, 1 o'clock to 2 o'clock. So you should have drawn a red color.
Madam, for the benefit of all the people, can you just explain how will you do a manipulation?
So you will draw a red line here, okay, and you will draw these vessels. And it is just only not saying 1 or 2. You have to say Schwal base line, Schwal base line, ATM, PTM. How is it possible that you have this patient who has gone into 360 degrees ectropy on UVA, NVD with rubiosis iridis, and this patient has no sine cave? You haven't drawn the sine cave. Okay, so you should have drawn the peripheral anterior sine cave. Have you understood, Elma?
Madam, for the benefit of all, can you hear me, ma'am?
Yes, very clearly, Dr. Gopal.
Yeah, for the benefit of all, can you just explain how will they do a manipulative gonioscopy versus indentation gonioscopy?
Okay, so when you have the 2 mirror, okay, you press on the cornea, okay, on the anesthetized cornea, and you ask there will be 2 mirrors, so inferior and superior. You ask the patient to look towards the mirror. So if you are doing, so if you have the superior mirror which is seeing the inferior angle, you ask the patient to look superiorly, therefore the inferior angle opens out. Okay, or you press the gonioscope where the superior mirror like this, you press it on the eye. So you either indent, you manipulate the eye yourself, or you ask the patient to manipulate the eye by looking into the mirror. That's called as manipulative gonioscopy. But the best one to do is the indentation. It takes more technical learning, but once you grasp hold of Sussman or Thor or whichever, use the personal lens and all of you must buy a gonioscope. An ophthalmologist in India who has no gonioscope of her own or his own is not an ophthalmologist, because gonioscopy in time can save the vision of the patient. Now, this patient, if we had picked it up earlier, where just the NVA had happened, you could have done what, Dr. Elma? Moment you had picked up the NVA at superior quadrant, let's say 1 clock hour, you should have mentioned how many clock hours. So let's assume it is 1 clock hour from 12 to 1. If this patient did not have ectropion uvea or rubeosis iridis, just for NVA, what would you have done?
A pan-retinal photocoagulation.
Pan-retinal photo. So first of all, before doing any PRP, you should have done a fluorescein angiography to look out for the areas of ischemia, to look out, and then done a PRP or a scat or a sectorial depending on the areas of ischemia. Now this patient has an NVD, so this obviously comes in the high risk category of DRS, and obviously now he has NVG, so this patient requires a full pan-retinal photocoagulation. How many spots would you aim at in 2 or 3 sittings, Dr. Elma, for PRP? Media is pretty okay. You can go for PRP in this patient. How many spots?
1,200.
At least 1,600. Okay. And do you do a PRP in 1 sitting, 2 sittings, 3 sittings?
3 sittings.
Usually 2 to 3 sittings. Okay. So that is what I want to show you about the gonioscopy.
I would like to just come in here to say that when you do pan-retinal photocoagulation, it depends upon your spot size and if the patient is a myope versus normal person, because in a myope, your area that you have to cover probably increases so much. And so this 1,200 to 1,600 is not a sacrosanct figure.
Because what you mean is you have to do a tight PRP. Basically, once the patient has gone into NVG stage, and this patient still has some visual potential, you want to really save him from blindness. So do a tight PRP. So 1412 to 1,600, but it has to be tight. Is that right?
Yes, ma'am. Yes, ma'am. Up till the aura, as much peripheral as possible.
Yeah,
and maybe half bandwidth.
Do you have Pascal there? Which one do you have?
No, we have an ordinary Zeiss.
You have the ordinary one. Okay, so go back to the one slide before. What do you mean by central anterior subcapsular opacity? Because moment you say anterior subcapsular, what does it mean? What does a glaucoma person like me think?
Glaucoma flecken.
I think of glaucoma flecken. Okay, then, but there's no visible glaucoma flecken in this picture, which is all right. Reinforcing, give a diagram. Go back better, one slide back, Yeah. Van Herrick's grade 2, fine tufting, 360 degrees. You written clearly no pass, right? Strange, no pass, then how has it developed 360 degrees ectropion UVA? Understood? Right?
Yes.
Okay, carry on, go forward. How do you depict microbullae in a corneal diagram? Now this patient has clear cornea. If you had to draw in a corneal diagram microbullae, how would you depict? You would depict it bullae as like this.
Small blue circle.
Okay, like this. So again, diagrams are very important. Next. Next slide.
One second. In the gonioscopic picture, when we describe gonioscopy, we will say which classification we used and what is the grade here, and what is the structure that we are seeing, and what is the structure that we are not seeing?
If you just write the structure, Dr. Gopal, if you let's say CBB, it doesn't matter whether it's cheese or spades or what it's open. If you write Schwalbe's line, again, you don't have to write as 1 or 2 or 3. So what we do in our center for the last 2 decades, we do is we just write the structure visible. And I'm sure if you remember at RPC also write the structure visible. Schwalbe's line going up to PTM, and especially going by the ICGO classification, you have to mention whether PTM, how much is visible. What do you mean by ISGO classification, Dr. Elma? What do you mean by ISGO classification?
Obviously, international glaucoma study group.
International. अभी तक वो खुला नहीं है, Google नहीं खुला क्या? All right, I leave this homework for you. It is not glaucoma. The G is not glaucoma.
Gonioscopy.
Remember, ISGO mein G is not glaucoma.
And so should we also mention the angle of the opening, like 20 degree, 30 degree approximately, and also the insertion?
Again, here, when there's so many, as I can see in this picture, you can see pass. Can you see if this is the superior angle being visible, you can see the blood vessels. And from, let's put it from 4 o'clock, 5 o'clock to 5:30, this is pass. There are a lot of pass there. Not even Schwalbe's line also is not visible. Okay. So you should mention what structures are visible. In this patient, if you really want to mention even the iris insertion, fine, but that's more important for open angles. For closed angles, iris insertion is not that important.
And the angle?
But the
and the angulation? 20 degree, 30 degree, like that?
No, not required. Just the what is the posterior most structure visible with manipulation or indentation? SL going to PTM or PTM going to CBB, that's what's important. Angulation is understood. So you if you write the structure, you write the iris insertion, and you write the iris configuration, like the concave iris, the steep iris, or the regular iris. There are 3 configurations. For this patient, NVG it's not important, but as a reflex, try to write it. Okay, and always write whether you done an indentation or a manipulate.
For indentation also, madam, similarly, that is
sorry,
for if you're doing an indentation gonioscopy also, we have to write like anterior trap.
Yes. How would the examiner know, bache aapne kya kiya? You have to mention whatever is documentation. You have to mention gonioscopy done indentation, or gonioscopy manipulation, or gonioscopy static. Again, ISGO classification is based on static gonioscopy. Okay. PTM not visible on static gonioscopy, not on indentation or manipulation. So it's very important what you have to write that. Go to the next slide. So we talked about the pupil. I wanted to write the diagrams. NCT somewhere you written 15.9 or something. I don't know what wrote. 15.7 left eye. Yeah. How can you have NCT 15.7? You don't have non-contact tonometry in decimals.
Yeah.
Okay. And again, for a patient who has had NVG in the right eye, the left eye is at risk, 100%. He has a vascular block in this eye. This eye is at risk. You need to do which tonometry? The standard is Goldman applanation tonometry. So again, you must learn how to do it so that in the exam you will be getting a GAT, and you should know how to do a GAT, right? Then why did I say pulse both sides? The history, remember I stopped you and said why not pulse? Because you had said carotid both sides. Why did you look for carotid both sides? What were you looking at?
Reduced volume.
You were thinking of
thickening of the
carotid artery occlusive disease. Okay, and would you do both sides carotid together? Never. If you go for an exam abroad, the examiner will be standing at your head. When I went for my FRCS exam, examiner was standing right in front of me. So they are watching you what you are examining. In India, unfortunately, we have so much rush and so many patients, it's not there. But if somebody decides to watch you, never do both the carotids together. You can cause a syncope to the patient. You will examine one carotid first and then the other. Okay. So you're looking for an ocular ischemic syndrome. Why did I ask for pulse both sides, right side pulse and left side? Takayashu. Okay, he's a 65-year-old smoker. He could have some occlusive, although Berger's is more common in smokers. But when you're thinking of ocular ischemic syndrome, pulses of both sides, carotid as well as radial pulses, both sides. Okay. What are the other causes of rubiosis? We talked about diabetes. We talked about vascular occlusion. This patient has occlusion. What is the third common cause? Third or fourth?
Ocular ischemic syndrome.
Sorry?
Ocular ischemic syndrome.
No, that's way down. That's way down.
Uveitis.
Central retinal artery occlusion.
Sorry?
Central retinal artery occlusion.
CRO में क्यों होगा बेटा? Vascular occlusion, CRO is the last to cause rubiosis because it causes total ischemia, causes blindness, not NVG. NVG is very rare with CRO.
So list the causes of rubiosis.
So first was diabetes, then is vascular occlusion. What else?
Central venous vein occlusion.
वो तो हो गया ना, vascular. First is DR, then is vascular occlusions. Third?
Chronic inflammatory conditions. Uveitis.
Yes, chronic uveitis. What else?
Where I will be operating.
Post-operatively, post-vitrectomy.
Yeah, so any complicated surgery, retinal surgery, even multiple strabismic surgery, but usually retinal surgery, old RDs, Coats disease, Eales disease, okay? And even glaucoma, even old glaucoma, chronic ACG, chronic OAG, end-stage glaucoma, you can have rubiosis. Okay? Then you come to ocular ischemic syndrome, temporal giant cell arteritis, Takayashu, malignancies, retinoblastomas or melanomas. Okay? But usually the first 2-3 are the most common, which you have covered. All right. Rubiosis, you've talked about. Differential diagnosis? Any differentials just for rubiosis?
For this patient?
Now, this patient actually there's no differential. 65-year-old vascular occlusion, rubiosis. But if you have something else, just rubiosis, you can think of Fuchs or chronic uveitis. Again, that will be the point. We will say normal vessel or abnormal vessel. Arborizing, superficial, and leaky vessels are abnormal. Deep, radial, non-leaky vessels are normal. Okay. All right. How will you? What is now? You have this patient. What is the vision of this patient?
In right eye, it was 3 meter counting fingers.
Right eye was
3 meter counting fingers, ma'am.
3 counting fingers, 3 meters.
And nobody
again,
says
go back. No, go back.
You say 3/60.
Always. In any glaucoma patient, any patient, you must mention projection of rays.
Yes.
3 meters, PR accurate, not accurate. Why is that important? So your vision is incomplete. Why is PR important?
In this patient, in glaucoma, there can be sectoral thinning.
No, PR is important. Moment the projection of rays become inaccurate, it means there is retinal ischemia and there is optic atrophy. Okay, so your prognosis becomes poorer. Immediately you may have 6/18 vision, but inaccurate PR, your prognosis goes down. You may have 6/36 vision, PR accurate, the prognosis will be better. So always vision has 2 aspects, visual acuity and projection of rays. Both have to be together. Got it? And second, you've written the last row is T plus R and B. What is this?
That is Refraction using tropicamide and phenylephrine.
Sorry?
Refraction, ma'am, the retinoscopy.
Now, what is T?
Tropicamide plus phenylephrine.
Okay. So what we write is, again, that's all right, but we write refraction under tropicacil and at what meter? 1 meter, 1 through 3rd meter, because that will, okay, that you should have written here. Next. So we've covered that, we've covered the findings. Now fundus is showing ciliary congestion, cornea was hazy. So you should have written was 6-year male chronic smoker. Again, with pain and worsening of definite vision. Defective vision, that means he was a myopic. He had already defective vision. He was a refractive error.
He was a hypermetrop, plus 3.5.
Okay. Plus 3.5 at a distance of 1.5 meter. That means he was at 65-year-old. He would be like 2 meters, plus 1. Okay, you would minus 1.5, so 3.5 plus 2. All right, so you should have, again, painful decreased vision in the right eye. I would have said 65-year-old male, chronic smoker with painful decreased vision, right? Left eye, he has no vision decrease, but he definitely has the findings. Right eye, ciliary. So right eye on examination, on presentation was congested, ciliary congestion, hazy cornea with ectropia and UVA, with iris rubiosis, occludable and rubiosis iridis, as well as rubiosis of the angle. With NVG diagnosis, आपने कहीं पर बेटा इसमें NVG, you haven't written NVG anywhere. Okay, so diagnosis, right eye NVG, left eye because of the infratemporal BRVO is definitely at a risk of going the same trajectory as the right eye went. So now what will you do? This is the patient. Right eye is already pretty much worse. Left eye can go this route. What is the advice you will give him, and what is the treatment you will give him, and what are the investigations you will do? So let's come to investigations first.
Before that, may I just ask her one question, ma'am?
Yes.
Yeah, what is the cause for 3/60 vision in this patient in the right eye? What are the causes for 3/60 vision?
You want to ask me the question or her?
No, I am asking her. No,
okay.
No, not you.
One of the causes.
No, what are the causes?
What are the causes? The patient has an subcapsular, anterior subcapsular opacity. It can contribute to the reduced vision. Then the patient might have had a ischemic CRVO.
What would be the cause? What he's asking is visual acuity reduces only when, now the cornea, after what your picture showed, the cornea was pretty clear and the subcapsular opacity in the lens wasn't that great to cause a commensurate loss of 360. What else you should have said? What is there in the retina?
What are the causes?
Retinal
macula. What was there in the macula? BRVO or CRVO, unless it involves the macula or causes vitreous hemorrhage, will not give rise to vision loss, no? So what was there in the macula?
Macular edema.
Was there macular edema on clinical examination? You have not mentioned that. Was there macular edema? No. Okay.
It has to be.
No. So otherwise, what is the reason?
If there is no macular edema, what else could have contributed to the defect?
Yes.
Optic atrophy.
No, macula. Any macular cause?
No.
Sir asked, no. Sir told if there is no macular edema, still the patient could have visual loss.
Combined with any ciliary artery occlusion?
No, let us have the other people talk. Shabina Bashir. What are the causes other than that? So we have some corneal edema, which you mentioned. We have some anterior cortical opacity, which you mentioned, which is not very significant. Then we have, ischemia, right? This is ischemia, and that is the reason why there is a rubiosis iridis and there is neovascular glaucoma. There is ischemia. So probably ischemia could be contributing. Can 55 pressure contribute to functional loss of vision because of an optic nerve dysfunction, which is reversible?
If the raised IOP is persisting for more than 5 days, they can contribute to optic nerve damage.
No.
What happens to the optic nerve when the pressure is very high?
There is loss of this axonal layer.
Sorry?
No, they are chronic changes, no loss of axonal, the RNFL, and they are all chronic changes. Acutely, when pressure rises to 50, 60 millimeters of mercury, what will happen to the optic nerve? Axoplasmic transport.
Stasis of the axoplasmic flow.
Yeah. Is that reversible? It is reversible. So the first thing, the most important thing that the patient is going to ask you, whatever you're going to treat, is how much vision will I get back, doctor? So for answering the question, you should know what is the contribution of each of the structures and decrease of vision that you mentioned right now, how much each component is contributing to the decrease of vision. So from your picture, I am not seeing a lot of ischemia in the retina at all. There is very mild dilatation of the vessel, very few hemorrhages. There is no significant macular edema. We could have been more wiser with an OCT, but we do not have that. But clinically, you did not mention about macular edema. So I think that there is no macular edema. And so we have 3/60 vision. So it is completely contributed by ischemia. Ischemia is not so much seen in your picture. Okay. So maybe I think with an absence of so much of corneal edema or cataract or visible ischemia, I think the visual loss of 3/60 may be more contributed by the functional optic nerve dysfunction caused by high intraocular pressure, which can return if your pressure you can rapidly reduce. Okay, madam, over to you, ma'am. Sorry.
Okay. So you have to rule out macular edema 100% because the vision loss, as you correctly said, is cornea, lens, anything which comes in the light pathway. Prior to the cornea, lens, vitreous hemorrhage or macula, and then the optic nerve pathway would cause vision loss. So how will you manage this patient? What investigations you will do? What will you order? The investigations, you have everything available for you. What all will you do?
I would like to do a fasting blood glucose level and postprandial fasting lipid profile.
So you want to check the lipid levels and the glucose levels. All right. You want to rule out diabetes and hyperlipidemia. What else?
Elma, do you have future other slides in the slides? Further slides? Do you have further slides? Yes or no?
Yes, sir. I have one diagnosis page and investigations.
Okay. Okay. So madam is asking what investigations. Please show her the investigations, please. Whatever you have done.
So serum homocysteine, what did you do?
Because since the patient had no comorbidities, the occlusive event could have happened because of any hyperviscosity.
Yeah, but 65-year-old smoker, bilateral vascular occlusion, I would not put cysteine so high. Cysteine would be when you can't find something else, younger patient, no other comorbidities. All right, APTT, coagulative profiles are normal. Again, next. Next slide. Carotid artery Doppler. What are the indices in Doppler?
What, ma'am?
What are the values in Doppler? When you do a carotid Doppler or ocular blood flow Doppler, what are the indices you look in the artery or the vein? Some velocities. What are the indices?
We look at the media thickness. If there is any flow limiting pathology.
No, the radiologist would do it. No, this would be done by the radiologist. What would he tell you? He would give you some indices.
If this stenosis is more than 70%, it indicates.
No. Anybody else?
Madam is asking about the flow velocities, the resistivity index, all those things, the quantific indices.
How would the radiologist quantify it for you? Anybody else? I don't know the names, Gopal. You have to guide me for the names. Anybody else wants to speak?
Najla, Najla, are you there?
Yes, madam.
Najla, we would like to see you also. Can you on your
Switch
video?
on your videos.
Please, all of you, please switch on your videos. If there are no further slides, are there more slides coming in?
No, sir.
Then we can stop the presentation.
Yeah. Then stop. Then let the videos come. Let the pictures come. Let the people.
You can stop sharing. You can stop sharing, please. Ankit, you can stop sharing. Ankit, you can stop sharing, please. Okay.
All please switch on your videos. Jamie.
Okay. So Rehna, Rashid, Najla, Shejia, Shabina. Who would want to talk about the Doppler indices, ocular blood flow? So it won't take. It's already 8 o'clock. It is end diastolic velocity, peak systolic velocity, and the most important is resistive index. Okay. So it will happen for carotid artery, for ophthalmic artery, and for central retinal artery, and also for the most important artery for glaucoma, which is not always same, is short ciliary artery. Okay, short posterior ciliary arteries. So how will you investigations done the Doppler
important in CRVO or RVO? Is carotid Doppler important in RVO, or is it important in RAO?
Important in CRA. AOs, arterial occlusions.
More important in retinal artery occlusions. Okay. Because you are telling that there will be plaques in the carotid, 70%.
Also, they would tell you whether there is any atheroma in the vessel wall. Yeah. Okay, one is the flow indices and atheroma, because if there's atheroma, then you need treatment for that. Just telling it's resistive, this would not be, they would need to find a pathology. Okay. So you have done the carotid Doppler, the blood profile, the homocysteine levels. What else would you want to do?
I would like to do a peripheral smear.
Peripheral smear? Why? You want to rule out leukemia, lymphoma, anemia?
The patient is coming from a region is endemic to the sickle cell disease. So I would like to rule out any sickle cell.
Sickle cell, 65-year-old male coming to you for 65 years, he was fine. And today at the age of 65, he's coming to you with vascular occlusion. Think of sickle cell? No, sickle cell would have happened in first and second decade. Something would have happened then.
So Elma, at a 65 years old, what madam is telling is, a normal person, he will have atherosclerosis, he will have hypertension, he will have what is called aging, and all these will contribute. You don't have to be very, very enthusiastic in finding out, sickling or homocystinuria or protein C, protein S at 65 years of age. Okay.
Yeah.
Yes,
so look over hypertension, atherosclerosis, diabetes, you said. You have ruled out bleeding disorders. Again, not so common at the age of 65. Any malignancy, all right. Although it doesn't look like embolic, but still. What are the other ocular examinations you want to do? He's a smoker. You would want to do extra chest, I'm sure. If you want to think of malignancy, think of then, chest X-ray. First, lung cancer would be there if you think of cancer. All right. He's a chronic smoker. What are the ocular investigations you want to rule out or want to do?
Let's ask somebody else also, ma'am.
Yeah. Shabina?
You can unmute.
Yes, ma'am.
Yeah. What are the other?
Ocular investigations.
Ocular examination, ocular investigations?
We can do an OCT scan.
Yeah.
OCT. Before OCT, what do you want to see? What do you want to look for?
The macular area, the macular edema.
So you want to look at the macular thickness and the macular edema and the ISOS junction. How long has it been there for prognosticating? Okay, what else? I'm more bothered about the other eye, which hasn't developed rubiosis nor NVD yet. We just talked about the test which you do to rule out ischemic from non-ischemic. Which investigation you'll do to rule out ischemic BRVO from non-ischemic BRVO?
Fluorescein angiography.
Fluorescein angiography. Very good.
Fluorescein angiography. So you'll do a fluorescein angiography. To rule out macular edema, at what stage will you continue the fluorescein angiography? You will take the pictures at what stage? How many minutes? What is the late stage?
Late stage.
What's the late stage?
Venous stage.
Venous stage would be the very early. It starts at arterial phase. Which is the first phase?
Choroidal phase.
Choroidal flush is the first phase, then arterial, then arteriovenous, then the late phase. So late phase happens what? 10 minutes, 15 minutes, 30 minutes, 1 hour?
15 minutes.
15. Anybody wants to disagree with Najla? Or agree with Najla? Who all agree with Najla? हाथ तो ऊपर करोगे नहीं करोगे?
मैडम तो डेमोक्रेटिक है.
So late phase is not 15 minutes, it is 30 minutes. You have to, if supposing you have a big rush of angiography patients, you will do till 10 minutes and call the patient back at 30 minutes and then check again. Okay? Because the macular edema can happen till the late stage, can be 30 minutes. All right, so you do a fluorescein angiography. What else would you want to do? OCT you've done the fluorescein angiography. Anything else?
In an RVO, prognostication is given by one particular investigation, which is not very frequently done, but it is mentioned.
Okay. Yeah.
ERG.
Pardon me?
ERG.
Yeah, ERG.
Yeah, but ERG again, he's right. You can prognosticate with the B waves, but you would not really want to go for ERG in this patient. All right. In the B wave, what do you look for prognosticating? If Dr. Gopal is asking.
Amplitude less than 60%.
You look at the oscillatory potentials. Okay. OPs you look at the ascending limb of the B wave. How will you manage this patient? You've done the investigations. The FA is showing you a lot of ischemia, more than 8 to 9 capillary non-perfusion areas in the seeing eye, better eye, left eye, right eye obviously has NVD. It's a frank NVD. How will you treat this patient?
We can give a pan-retinal photocoagulation.
Which eye will you do first? Right eye, left eye? Both eyes. You'll do the right eye first, but you will not wait too long to do the left eye, especially if you found an ischemic aspect. You'll do a preventive PRP. Both eyes. Okay. What else?
Currently, ma'am, I think if somebody...
What else? Other than PRP, I was going to ask, what else can you do in addition?
Subcyclo photocoagulation in the right eye.
Pressure, remember, was 52 in the right eye. Pressure was 52 in the right eye. What will you do?
Medically try to.
We won't control the pressure.
We can give IOP lowering agents like mannitol to reduce the IOP.
So systemic hyperosmotics
agents to reduce the IOP. So then we can go for a pan-retinal photocoagulation. Then subcyclo photocoagulation can also be done.
What are the principles of managing NVG? 4 principles. 4 principles. One is reduce the IOP. Second is reduce the source of the vascular growth factor and endothelial growth factor. No, VEGF, you want to reduce the VEGFs. That's what causing the rubeosis. If you want to treat that source has to be stopped, the IOP has to be reduced, and the inflammation has to be reduced. Okay? Right? And the ischemia element has to be taken care of. So to ischemia element, you are doing a PRP. Can you give PRP and anti-VEGF both?
First we have to do PRP.
First you do a PRP, all right. You wait for how long? For the response to come, for the NBD to regress, for the NBI to regress? How long do you wait? Patient says, Dr. Saab, when do I come back to you?
1 week.
1 week. The PRP effect comes within 1 week? Yes, Shehja? Reena?
Rehna is my
Yes,
assistant
ma'am.
professor.
Okay. All right. Now I can't differentiate. You haven't identified. You haven't introduced me to your people. So how do I know? Yes.
Shehja, you can answer, please.
3 weeks.
3 weeks. Can we bargain a little bit? You wait for 6 weeks. Okay. The response for PRP usually starts coming by 2 weeks, but you wait till 6 weeks. For the response to anti-VEGF comes faster. It comes within a week, but it will take maximum till 3 weeks for that. And which one is permanent? Which response is permanent, PRP or anti-VEGF?
Yeah.
Shabina? Which one is permanent?
PRP.
Yeah. So any anti-VEGF is a transient effect. Therefore, if you do PRP, you wait for 6 weeks, and the rubeosis is still there. You want to control the intraocular pressure. In that situation, you may go for an intravitreal, intracameral anti-VEGF.
Intravitreal.
Which one, Shehja? Najla, which one?
Intravitreal, madam.
Why not intracameral? The vessels are in the iris, no? Run a PRP behind.
Source of anti-VEGF is.
So the source of VEGF is the retina. So it is always, now there are two schools, there are 2-3 schools of thoughts. Some people say give both, but intravitreal has to be given. You may club it with intracameral. We've done both also, because you want the vessels of the iris to go back. And then you do which glaucoma surgery would you want to do, Elma?
Modified trabeculectomy. Modified trabeculectomy procedure.
So you would do trabeculectomy with antifibrotics. Okay, I would prefer to do trabeculectomy. Many people would go for a tube shunt, but I would still always, the first thing is trabeculectomy. If that fails, then you can think of a tube shunt. But this patient is phakic. AC is not too shallow, so tube shunt also can be given. But obviously, then the lens status has to be explained to the patient that they may need a cataract surgery. Would you want to do a combined surgery in this patient? Trab and a phaco together? He has anti-subcapsular cataract. He's 65-year-old. After 5-6 years, he'll again come back to you for cataract. Why not do it together? Shehja? Together or alag? Staged or together? Always staged, because combined surgery has more inflammation, and already in dubiotic glaucoma you have inflammation. So you want to do a trap, control the pressures, let the eye quieten down, and maybe 2-3 years or 6 months, depending, you do a phaco afterwards in a quiet eye. Okay, you never touch an angry person, you never touch an angry eye so much. All right. So I think we covered the gonioscopy findings, the pupil findings, the diagnosis, the tests, and PRP. What is another question somebody can ask you is the anterior retinal cryopexy. When do you do that? And if you had to, other one would be if you had to give an anti-VEGF, although I agree with you people, you can do a PRP. Anti-VEGF is a second. If you had to give an anti-VEGF, which one do you prefer? Bevacizumab, ranibizumab, or aflibercept? Which one do you prefer? And why? That's another question, Gopal. You have the next retina thoughts. Ask them that time.
Yeah.
Avastin, because it's the cheapest, most economical, and it's effective. But and for rubiosis, it's pretty effective. Diagrams I've told you: pupil margin, gonioscopy, NCT. Yeah. You also have to tell him to stop smoking, okay? Because that history of systemic, unless you control the smoking, what does smoking cause in the eye? What are the studies of smoking? What all has smoking caused in the eye? Evidence-based. It's been linked with ARMD. It has CNVM. It has been linked with ocular blood flow. It has not so far been linked with glaucoma so much, but definitely with ocular blood flow. So you have to ask him to stop smoking because the nicotine is going to cause vasoconstriction and the ischemia at the optic disc would become worse. Although this optic disc doesn't appear so bad. It's pretty good color from the pictures. Okay, over to you, Gopal.
Thank you, ma'am. So I would just like to add that, in neovascular glaucoma, you have different stages. Did you also tell which stage of neovascular glaucoma we had? Which stage?
That she already said, angle closure stage. Yeah, she said in the beginning. Okay. That's why I said without pass, how can you have ACG? That's exactly what I said, that you should have had pass.
So I was, after her gonioscopic description, I was thinking that this is more of an open angle. It is not completely closed. And that is why I was thinking that if you put in an anti-VEGF agent, immediately the neovascularization will melt away. And probably you will, when you do a gonioscopy.
Only thing is, Dr. Gopal, if you have a 360 degrees ectropia on UVA, that means the fibrosis has happened. Correct. How will the fibrosis happen if there's no pass?
There should be a lot of pass all around.
There should be, and there is. In the gonioscopy picture, you see it, there is pass. They haven't just mentioned it. If you understand the pathology, the pathophysiology, ectropia on UVA, it has to be pulled out. The posterior iris pigment has to be pulled out. And somebody has to be pulling it. So pulling it is fibrous tissue. Fibrous tissue has to originate from the rubiosis, from the angle, and it has to have pass there. It can't cause ectropia on UV and not cause pass.
Yeah, and that is why Madam said that we will primarily take the patient up for trabeculectomy.
Yeah.
Otherwise, we could have waited. We could have maybe post anti-VEGF and PRP. We could have medically managed also if it is an open angle stage. And a lot of people do well with that. Because once the VEGF significantly reduces,
PRP anyway you need, even if it is open angle, stage, moment the vascular occlusion has caused rubiosis, you have to have a PRP because all the anti-VEGFs will only have a temporary effect. Okay, 6 to 8 weeks. Again, the rubiosis will come up. PRP is the one which has a permanent effect. All right.
Thank you very much, ma'am. Rehna, you can close down the session.
So we have come to the end of the case discussion today. That was a very meticulous case discussion. Thank you, Kirti ma'am. Going through each and every detail and correcting each and every mistakes that they have made and stressing the importance of each and every examination, diagrams, projection of rays. That's really good. Thanks a lot. Thank you, Dr. Sandhya, for that. And I would also like to thank Dr. Elma, who presented. And next week, as Gopal sir have said, we'll be having photos on retina.